Hey everyone! Today, we're diving into the official playbook for managing diabetes in the hospital. And look, this isn't just about tweaking a few numbers. These are the real deal standards of care that keep patients safe and actually improve how well they do. Let's get right into it.
So here's our game plan. We're going to follow the patient's journey from start to finish. We'll start with the challenge itself, then hit the critical first 24 hours, break down the modern insulin playbook, tackle some of the trickiest clinical hurdles you'll see, and finally, make sure we nail the discharge plan. So first off, why is this such a huge deal? Well, when a patient's blood sugar spikes in the hospital, it's not some minor blip on the radar. No, it's a serious red flag, and it's directly tied to a whole bunch of bad outcomes. That's why getting this right isn't just important, it's absolutely non-negotiable.
Okay, let's get our terms straight right from the get-go. According to the American Diabetes Association, hyperglycemia in the hospital is defined as any blood glucose reading over 140. That's it. That's the official line in the sand where our attention needs to be laser-focused.
Now, while anything over 140 is a concern, the goal isn't some unrealistic perfect number. It's all about stability. For pretty much all hospitalized patients, the evidence-based target, the sweet spot, is keeping their blood glucose somewhere between 140 and 180. And you have to understand, this range is everything. It's the safety zone. When we keep a patient's glucose levels here, the data is super clear. Their hospital stay gets shorter, and the risk of complications plummets. Honestly, the whole inpatient playbook is built around hitting and staying in this zone.
And that brings us right to the starting line, the moment a patient is admitted. These first 24 hours are, without a doubt, the most critical window. What you do here sets the tone for their entire hospital stay.
So, what are the absolute must-dos? There are 3. First, you got to get an A1C if they haven't had one recently. Second, you need to know exactly what type of diabetes you're dealing with. And third, you have to find out what they already know about taking care of it themselves. These aren't just boxes to tick, this is crucial intel.
That A1C test, it's like a little time machine. If it comes back at 6.5% or higher, that's a dead giveaway that diabetes was an issue long before they ever got to the hospital. And that tells the clinical team, hey, we're not just dealing with stress-induced high sugar here. This is a chronic condition that's going to need a solid, long-term plan when they leave. Okay, let's get to the main event, how we actually manage the blood sugar. The modern way of thinking is all about being proactive, not reactive. It's a huge shift from the old days of just chasing high numbers after they've already happened. This right here shows the two completely different philosophies. On one side, you have the gold standard, the basal bolus plan. It proactively covers the body's 24/7 background insulin needs and adds extra for meals. On the other side, the outdated sliding scale only method, which the ADA pretty much begs people not to use because it's purely reactive and fails to address the root of the problem. So how do we kick off a proactive plan? It's not guesswork. It starts with this really simple weight-based formula. You just take the patient's weight in kilograms and multiply it by a factor somewhere between 0.3 and 0.6. That gives you a safe, evidence-based starting point for their total daily dose of insulin, or TDD. And the next step couldn't be easier. You take that total daily dose and you split it right down the middle. 50% of it becomes their long-acting basal insulin. That's the foundation that works all day long. The other 50% is for prandial insulin, which you'll divide up to cover their meals. It just makes perfect sense. But of course, medicine is never that simple, right? A standard plan is a fantastic starting point, but let's be real, things get complicated. So what do you do then? Let's talk about a few of the most common hurdles that require some expert adjustments. We're going to zoom in on 4 really common scenarios. What to do when a patient isn't eating, when they have kidney failure, when they have type 1 diabetes, and when they're on steroids. Each of these situations demands a very specific, careful approach. Now this one is a big one. It's a common and incredibly dangerous myth. You might think, well, if the patient isn't eating, if they're NPO, they don't need insulin. That is dead wrong. Your liver is making glucose around the clock, so patients always need that basal insulin to cover it. You just hold the mealtime doses. Next up, kidney failure. Think about it. The kidneys are what clear insulin out of the body. So if they aren't working right, that insulin just hangs around a lot longer. This dramatically cranks up the risk for hypoglycemia, dangerously low blood sugar. It almost always means their insulin doses need to be carefully lowered. Steroids. Medications like prednisone are famous for making blood sugar go wild. But here's the cool thing. It's a predictable pattern. The glucose spike usually hits in the afternoon. So the playbook has this really clever countermove. You use an insulin called NPH and give it at the same time as the steroid. Its peak action lines up perfectly to fight off that glucose spike. It's a beautifully targeted strategy. And this might be the most critical point of all. For someone with type 1 diabetes, their body makes zero insulin. Basal insulin isn't just for controlling sugar, it is life-sustaining. As the ADA says in no uncertain terms, just giving them correction insulin is contraindicated. You cannot hold their basal insulin, even if they aren't eating. It's what prevents a life-threatening emergency.
All right, we've made it to the final, and frankly, one of the most vital phases, the discharge. A perfect hospital stay can be completely undone by a messy transition home. The journey to safety absolutely does not end at the hospital door.
A safe handoff really rests on 3 pillars. First, you've got to do a super careful medication reconciliation, making sure the home plan and the hospital plan actually make sense together. Second, clear, structured communication with the patient's outpatient team is a must. And third, you need to teach the patient these survival skills, how to actually use their meds and check their sugar at home.
And finally, the plan has to include a follow-up visit. The guidelines are clear. Every single patient should have an appointment within 1 month of leaving the hospital. This is the safety net. It's the essential check-in to see if the plan is working and to make tweaks before a small issue becomes a big problem.
And all of this leaves us with one final massive question. We have the playbook. We know what works. We know how to keep patients with diabetes safe. The challenge isn't knowledge, it's execution. Are our systems actually set up to follow this playbook for every single patient, every single time? That question right there, that's the gap between knowing the best standard of care and actually delivering it.